Okay. All right. Hi, everybody. My name is Jade, and I welcome you all today. So today's webinar topic will be on why is soft tissue relevant in implant dentistry. I would like to inform you that you may receive 2 CE credits for today's webinar. You must stay active during the whole session, and at the end of the webinar, you will receive an email from TDIA with the course evaluation form. Once you submit the form, you can expect to receive your CE certificate by email within 14 business days. We will also have Q&A session after the lecture as well. So yeah, without further ado, I would like to introduce you to our speaker for today's webinar, Dr. Jen Kim. So Dr. Jen Kim is a 1986 graduate from the dental school at University of Sydney, Australia. He completed specialty training in periodontics at UCLA School of Dentistry in 1998. Dr. Kim is board certified by the American Board of Periodontology and the American Board of Oral Implantology. He has advanced degrees in pathology, public health, oral biology, and had been in general practice and academia for 9 years prior to starting his career in periodontology. He has spoken at many national and international meetings worldwide, and his research has been published in respected scientific journals. He is also the co-director of GDIA. So with that, I ask that you give Dr. Kim a warm welcome.
Thank you, Jade. Thank you for the nice introduction. And it's a great pleasure to be in front of this nice group of Dallas clinicians. I hear that you guys are doing a lot of fun things over there. I recently was able to meet up with a few of you guys that came down to Tijuana, Mexico to do some surgery with us, and we had a lot of fun. So I have some fond memories of you guys. Why is soft tissue relevant? This is a topic that I particularly like, and it's a topic that is in my opinion, as important as any other topic in implant dentistry. But here is what tends to happen. When you're in the infancy, early stages of implant dentistry, this whole vision of soft tissue and the relevance becomes quite vague, because you're predominated by just getting all the basics done. And there's a fear factor, there's anxiety because you're not an expert yet. You just want the implants to work, you want the patients to accept you, patients to like you. And then as time goes and implant cases are done in bigger numbers and you follow up for longer periods of time, then you all of a sudden realize what's happening here, what's the problem? And many times that problem, what's happening, that problem is actually soft tissue. That is a story that is quite common, and most of the more experienced clinicians will say exactly that. So in the next hours or two, I'm going to cover some of these relevant topics and try to walk many of you clinicians into the right path and guidance so that you can truly enjoy implant dentistry without getting bogged down to these kinds of challenges. This is a lady I treated, as you can see the date, 2003. When she first presented, what's on the top, she's wearing a partial denture, the so-called estate plate, and she needed dental implants. So she was referred in from outside. And when I looked at her, I asked her, how do you like your lower teeth? And she says, I don't. Is there something that can be done? And obviously, there's a lot of things that can be done. It's just that somebody really didn't put the 2 and 2 together, and they were preoccupied by the missing teeth situation. So I talked to the patient, came up with a treatment plan, and the patient basically decided to have a orthodontic therapy. So orthodontics was completed, and then the teeth were rolled in and made into much better alignment. What you see, the lateral, what's supposed to be in the lateral incisors are adjacent to the canines are actually composite resin. They're, ridge slab pontic, as you can see, that was chair side done. It was actually bonded. And the way that has remained ever since 2003, 2004. What had happened here several years later, she had received a large piece of gingival graft. Going back a couple of slides, These teeth have compromised root support. Hopefully the occlusion is good, but soft tissue is very thin. When you see gingival recession, this is what I want you to think. Gingival recession equals to bone loss, bone damage. Many times we don't realize them ourselves, and many times we don't convey it to our patients. When the gum is gone, a lot of people trivialize it. Oh, the gum just, my teeth are longer. It just comes with age. Yes, all those are true facts. But true fact is that when soft tissue is gone, it could not have happened unless bone damage has happened. Once you put those two and two together, you should see the eyebrows of the patient. They go like, what? You mean I have bone loss? No, I have gum loss. Yes, you have bone loss. And that is a good starting point for patients to realize what's going on. Now, the reverse is true. Now that the soft tissue has been added here, as you can see by chunky keratinization, very healthy gingiva with very thick keratinization. When you do this, and if you were to cut out a piece of histology and looked under the microscope, guess what you see underneath all that? Bone. You heard it right. New bone grows underneath free gingival graft. This is something that has been well known in the periodontal community and academia for quite some time, and that this is what you need to tell your patients. The gingival graft does not only make the teeth shorter and perhaps bring the gum back to where it should be. Many times it's for root coverage. Many times it's to get some more soft tissue band, a stronger zone of soft tissue. All of the above is true, but the one word they really need to hear from you is to say, hey, this is to get you more bone that was lost. We tend to reverse that. So this is now 12 years later, the bone is good, soft tissue is good. So this is the humble beginning. This is after meticulous work of orthodontics, periodontics, and of course, upstairs, we had actually done dental implant work. So this is my patient in the beginning, and let's walk through this. A very crude surgical guide. Whether it's crude or not, I highly recommend you make surgical guides because it's the effort. Having said all that, today we tend to do more digital, which is great. And if you guys need to learn more about that, please take Kevin Kim's course. Kevin Kim is one of our faculty. He is one of the digital gurus in our group. And he constantly gives courses, I believe the next one's in January, about how to make surgical guides using software and so on. So 3D printing, that should be a very good course. Here, I'm going to freely admit, I made the guide, which should work, but I actually made a mistake. I want people to look at this and pick out the mistake. It's not bad photography. It's not wrong implant system. It's just bad implant placement. And it will be apparent. You see, implants were placed. I thought they were in good position, but I was, of course, wrong. And this is early healing. What you see there are a couple of customized healing abutments. So we can start to form the soft tissue, cuff, the gingiva, the papillae, all the right components. That was the whole intention of it. But as you realize, those implants were placed way too facially. When the implants are placed facially, it really doesn't leave room for soft and hard tissue. So at this point, I am struggling to try to get the soft tissue mass and volume. And here is a customized milled abutment. This case goes back 2003. Some of you guys were not even born back then. This is almost a 20-year-old case. And this is what's known as customized milled titanium abutment. Brand-wise is Atlantis. Today, this is very commonplace. You have true abutments. We have all sorts of milling available readily. Each major implant company does them. Large lab groups do them, and so forth. But this was the very beginning. This was actually the Atlantis, the original. I used to lecture with the founder of Atlantis, and this was one of the lectures that I actually gave at that time. So these are made. The Atlantis is a company, the milling company. Right now it's under Dentsply. You send the case over to them. They mill these. They mill the provisionals and send them back to you. Now it's all done through local labs. So you fit these through, and here we go. This is on the master model. And you can see on the purple one, you can see how tight that embrasure is, how rapid the emergence is. In other words, from the facial contour of facial most portion of the implant platform, which is the junction between silver and the purple, to where the gingival margin of the restoration is a rapid, almost a 90-degree turn, which this will come later. I will be explaining this. Soft tissue does not like rapid turns. Soft tissue in your body, think about it from head to toe. Every piece of soft tissue, if you differentiate soft and hard tissue, that is, there is no place in human body where there's a sharp corner that soft tissue exists. Soft tissue always exists in curves, never 90 degrees. So if we create something that's 90 degrees or close to it and say, hey, soft tissue, this is your new environment, live here, they won't. They simply don't live there because it doesn't belong to their normal physiology. So these are some of the slides of what you saw. But here, see, as early as 2016, now you start to see the gingival margin. The gingival margin has moved away, and you can actually see the abutment margin, rather. And luckily, patient has low lip line, and she's loving it. And, I got away with this one. This is her. She's a Facebook friend. And let me see. She one day posted this picture, and everybody was commenting about how beautiful her teeth are. And, of course, look at the very bottom comment. It's a beautiful teeth. I'm biased. Of course, I'm biased. That was my case. So what is the function of soft tissue around teeth? Let's go through some fundamentals. Soft tissue around teeth function as the following. Number one, attachment to teeth. Without the soft tissue, attachment cannot happen. Somewhere in this diagram here, you guys know that there is what's known as the Sharpie's fibers, the Sharpie's fiber and the oral epithelium, the sulcular epithelium, and so forth. But, all of these gingival attachment apparatus combined make the teeth attach. And of course, the next immediate question is, do we have something similar for an implant? And the answer is no. Secondary function of the soft tissue is immune and defense system. That soft tissue network houses this amazing defense system so that, look at this challenge, all this disease and pathology and microbiota, all of these attack on the human body is somehow kept nicely defended because of the soft tissue that brings all the good things, components to the area. It's also known as the drape. It covers everything underneath, like the tablecloth will cover ugly table, make the tabletop look pretty. It's a drape for cosmetics and phonetics. And could you imagine a beautiful face like this without the gums? That's just unimaginable. You see, this is a good example. Underneath all that, there is darkness, there is cracks, and there's all sorts of things. But, when there's thick, soft tissue covering it, all you see is nice pink coral color and perhaps some gingiva and some papillae and so on. Also, besides supporting the immune system, it brings blood supply to the area. It also brings blood supply for the bone that sits immediately underneath. So there are many things that soft tissue does for natural teeth. Sometimes you have way too much, in which case we tend to trim things away and using all kinds of methods. And, this brings on the topic of what are we looking at. A sulcus is a normal, healthy architecture. And when the sulcus becomes hyperplasia and there's more tissue than necessary, we tend to call it the pseudo pocket. In this diagram, it calls it gingivitis. Basically, it's gingival overgrowth. Sometimes we have way too much gums. Sometimes we have gummy smiles that people just simply don't like because there's a little bit too much. And this is technically called the excessive gingival display, or some people like to call it altered passive eruption. Kind of a weird definition, but let's see where that's coming from. See, this kid is supposed to have eruption of teeth. Young kid, deciduous teeth. But when the teeth don't come through, which by definition is altered eruption, And people believe there are two sets, two stages of eruption. One is the active phase where the teeth comes through, and then there's a secondary stage where passively gum moves away. Teeth are stable, but the gums tend to move away. So by the definition of altered passive eruption, what they're saying is teeth came through, but the gum didn't move back. So that is the terminology that got stuck. Whether it's actually true or not, I don't know how accurate that is. In fact, I think it's been debunked. But basically, that's the kind of terminology that we get stuck with. So too much. In this case, a young kid with gingival fibromatosis, the mother was extremely concerned. So under anesthesia, I brought the kid in, took out the deciduous teeth, took out a chunk of fibrotic tissue which was kind of impeding the eruption of normal natural teeth. And as a result, the teeth start to spring through, and you couldn't have a happier kid than the mother. So this is the kind of thing we're talking about. Sometimes you just don't have enough. Take a look at this lady. Obviously, wear and tear, parallel disease. Many things have led to the fact that this has ultimately disappeared. When it disappeared, the right thing for a clinician is to identify the reason. Why did it happen? How can we reverse it? How can we restore? We talk about restoring health, restoring the structures. Why are we not restoring the soft and the hard tissue? We restored the tooth, a bridge is in there, but technically that's not a restoration, it's an alteration. We never had, tooth-like structure all the way down there. So that is technically wrong. Same case, I took the bridge margin down and I covered the root with root coverage connective tissue graft. This is an old case, and you can see some scar tissue. We tend to do things in a slightly different way today. This is a 20-plus-year-old case where gingival graft was done to alter that cosmetic nightmare. This happens to be that same patient's daughter. The mother got some treatment. The daughter said, hey, I have the same thing. I need to get some treatment. So she comes in, same thing. We do root coverage by adding more soft tissue to the area, and happy mother, happy daughter. Here's another young gentleman that went through orthodontic therapy, and you can see how on the top image, the facial bone, soft tissue, everything is missing. And unfortunately, the clinician chose to simply slap some resin onto that surface. Oh boy, this is one of the things I really, really do not like. If it's a non-cervical non-carious cervical lesion, NCCL. If there's no caries or sensitivity or stickiness and so on, leave it alone. Actually, the best thing is to bring the soft tissue back. In this case, because there is resin on top, I had to take the resin off. I had to deliberately expose the root surface, root plane it, and then get soft tissue to cover. Taking a big risk, because if it doesn't work, you will end up with tremendous amount of hypersensitivity and so on. Too little. This is an older gentleman with wear and tear. He's actually an orthodontist. He was my landlord for almost 15 years, and he presents like this. So we had to bring him in. We treated him. This is alloderm, acellular dermal matrix. This is where older case, we soak this in platelet-rich plasma, PRP, and as a result of full mouth reconstruction, there was oral surgeon involved, the prosthontist involved, I did the soft tissue work, and as a result, we end up giving a very pristine, pretty look. Hopefully that will last many years to come, and so it is. It's actually happening. I'm going to drop into a case to get the get you guys going here. This is a young lady who has had a single tooth implant, tooth number 9, upper left central. As you can see on the right screen, the case is obviously finished at this point. What I want you to pay attention is the bone in the interproximal. The shape is almost identical, as if nothing has really changed, which is great. That means preservation is quite successful. So we are actually looking at tissue that hasn't changed very much. It is a dentist implant, placed quite deep. Pay attention to that implant shoulder relative to the adjacent bone or the CEJ. We're talking about 3 millimeters away. But when you look at the soft tissue is ideal. We have papillae with no black triangle, no black hole. And when you look at it from the side, this is an image that you may all want to look and remember. On the facial, immediate facial of the patient's implant, there is chunky bone-like structure. We don't know if it's bone. We hope it is, and we think it's bone. But based on the radiographs, there's a lot of bone that was missing in pre-op. But after the case was completed, we have adequate amount of bone besides the soft tissue. So you may want to take a screenshot, an image of this. This is what you need. You need facial bone of 2 millimeters thickness as one of the most basic requirements. We also need the soft tissue to be thick. At least 2 millimeters. Later on, I'm going to go over this one more time. Some of the parameters have changed. You can assume the 2, but 3 is the new norm. Presence of keratinized gingiva, the band has to be about 2 millimeters or more. This one hasn't changed for decades. You have to have adequate amount of vestibule. You need to have no bleeding or inflammation. You need to have lack of mobility, lack of staining and deposits, lack of pain. Occlusion has to be functional. Implant restoration has to be cleansable and maintainable. And then, of course, the patient has to have complete function. Cosmetics, chewing, phonetics, all of that has to happen. You may vary these variables and factors, but this is what I consider to be the 12 essential criteria to say that the implant is working fine. So, come up with your own criteria, but in my office, if none of these are adequate, then I would consider that implant to be problematic, and we will try to sort out solutions for that. Here's an example. Well, the first 3, I typically call them the rules of 2s. Like I said, I got messed up because one of the parameters has changed. Natural 2s, anywhere between 0.7 and 1.2. That's the norm. But around the dental implant, we expect 2 millimeters, which is kind of a double standard. This is literally a double standard. This is the classic paper that brought this concept to us. Robert Spray is a clinician out of the Veterans Affairs Medical Centers, and this was a prospective study where implants were placed on patients at the VA hospital. And when the implants were placed, they did calibrate and measure the bone thickness, the buccal thickness. They did not load the implants. They basically placed the implants, submerged them, and then brought the patients back for a second stage uncovery. And at the time of uncovery, what they noticed was that if the critical number was not 1.8, it tended to lose bone without even loading the implant. So based on that, we assume that 2 millimeters seems to be the magical number, and this number comes back over and over. Empirically, many people agreed with this number, but this was the first paper 20 years ago, 21 years ago, that definitively put the final nail on this argument. You need 2 millimeters of bone, period. If you don't, you're in trouble. So that's how the first criteria was put on the list. The second thing is the thickness of soft tissue. When this lecture slide was made many years ago, I used to call it 2 millimeters, and I used to call this 3 the fundamental, the elemental rules of 2s. Based on, for instance, this guy's paper, Thomas Langhirkes is the gentleman that his claim to fame is the zero bone loss concept. And he gives online courses. He's a very prophetic teacher, prosthodontist from Lithuania. Buy his book. You got to read his book. It's a Bible. If you have a chance to listen to him, I highly recommend it. He's a very, very good academic and speaker. Based on these studies that him and his group have done, we all agreed, yep, there you go. Thick biotype, 2 millimeters makes sense. Thin biotype, less than 2 millimeters, we're in trouble. So we got into the habit of changing soft tissue parameters to be 2 millimeters. So as you can see, this is a 2014 paper on the right. The soft tissue happens to be more than 2 millimeters. The left, less than 2 millimeters. And obviously what's going on is if an implant is placed in the exact same protocol, the one on the left, you lose bone. The one on the right tends to not. So we tend to do that. So how do we do this? We change the phenotype. We change the case to be more like the right side. In other words, we do simultaneous soft tissue grafting, we place the implant deeper, we do things like that to overcome this thickness issue. Until this guy updated. This is probably about 3 years ago. This is right before the pandemic. And Thomas basically one day says, you know what, I changed the rules. It's not 2 anymore, it's 3. Now I have to make all this freaking slides again. Anyway, Thomas is basically a leader. He just didn't come up with that number one day. He has a lot of papers to back that up. So take my word, it's no longer 2, it's now 3. You need to have 3 millimeters of soft tissue to be able to maintain the bone. Now, keratinized tissue, this is a different thing altogether. You need to have thickness of 3 millimeters or more, but the zone of attached keratinized gingiva, as you all know, needs to be 2 millimeters. On this one, there's no argument about it. This is an old data. We go back how old? 1972. 1972, Harold Lowe, who now has deceased, he was the periodontist from Gothenburg. He came to the United States and he was the director of NIDR, National Institute of Dental Research, for quite some time. That Harold Lowe and Klaus Lang is still a very active periodontist academician. These two, when they were very young, they came up with this study. And this is a classical study. You should know this by heart. Literally, it's a study where they looked at dental students in Scandinavia, basically in Sweden, and young Scandinavian dental students in the 70s, which means they were young, Caucasian, smokers in their 20s. And in that healthy population, apparently, the ones that had less than 2 millimeters of keratinized tissue had more gingival exudate than otherwise. So you can see the graph there. If you have 2.0, 2.5, 3.0, you're in the safe zone. If you had 1.0 or 1.5 millimeters of attached keratinized gingiva, then even under health, even for young Scandinavian dental students, there was gingival exudate, meaning there was inflammation. Inflammation forms around lack of keratinized areas in natural teeth. So all of these things I'm talking about is relevant for dental implants. So here's a good example. This is an example of a patient that was actually self-referred. The patient came and sought me out many years ago, and the story goes something like this. She said an implant was done recently, and she's not comfortable. Things are hurting. She can't brush around the area. She can't eat. It's uncomfortable. So she went back to the original dentist who did the implant work. Not bad. I mean, it's pretty fair. You may say the bone on the top doesn't look perfect, but hey, this is an internal hex type of implant. And for that, it's forgivable. But what is damning in this case is the image on the bottom right. If you look at the facial aspect of that implant, notice how glossy it is. Notice there's lack of coral pink because it is lack of keratinized tissue. In fact, when the patient complained, the clinician went in, flapped this, and put some bone in, supposedly because he thought bone was missing. So by the time I got to it, when I carefully opened this area up and did partial thickness, flap elevation, I decided to leave all that bone graft mass alone. It was attached, it was still integrated, so I left it alone. But what did I choose to do? I basically took a huge chunk of keratinized tissue from the palate and did a free gingival autograft. By basically bringing the gingival graft there, I'm trying to increase the zone of keratinization that causes this to be a natural barrier. Crown lengthening is performed on that second molar. And after healing, look at this beautiful keratinization, healthy. She's able to eat. She's able to brush the area, and the patient went back to normal functional life again. So this is the type of thing that keratinized tissue can do. And if natural teeth need them, dental implants definitely need them. So 2 millimeters. So that's pretty much where we are. So having said all that, let me walk you through. I'm going to give you 10 tricks as to what we can do coming Monday. After the weekend, when you go back to see the patients, these are the 10 strategies that you can employ on your cases to be able to be an expert on soft tissue. And the first one is simply increase the zone of attached keratinized tissue, just like the one you saw in the very last case. Graft soft tissue before the implant, not afterwards. You know why? Because if you do afterwards, you may have to do it for free and have to call it the free gingival graft. Okay, that's supposed to be a play on word and joke. But, the real reality is you can't say, well, I think you need some soft tissue now. Let's do some soft tissue graft. It'll be X amount. Chances are patients aren't going to like that. You said the implant was going to work, but now I need to have more work done. I'm not paying for that. That's typically the case. So do the soft tissue work before. So let me give you an example of that. This is Christine. Christine is a young, attractive lady. She played volleyball and then she got elbowed in the face. And this is what happened. Tooth got dark, devitalized, the endo was done, the tooth starts to get lost and then loose, and then slowly it emerged. It got to the point where the tooth was hopeless. So she was referred in by a general dentist in Los Angeles area. And he said, I'm counting on you. I want you to do a single tooth implant. I want to make it immaculate because they're an important patient to me. I said, yes, sir. Let me get to work. Well, when you have lack of facial bone, this is a very, very extremely difficult case to begin with. Okay. So what do you have to do? This is not an immediate case. This is a case where you have to stage. So I basically opened up the flap, cleaned out the debris, and you guys know the basics of soft tissue socket management. When you manage sockets, the key thing is inside the socket, you want nothing but bone-forming cells. Cells can potentially grow bone. What does that mean? If you look at the upper colorful image, you see bone that's exposed. You also see decortication. Basically, you see drill, small diameter round drill that went in through the cortical aspect, went into the marrow space and allowed pumping of this blood into the area. Not only that, you should not have any soft tissue tag around this area. That's the key, because if you leave some soft tissue behind, soft tissue outgrows bone, and therefore the socket will be filled with soft tissue and not necessarily hard tissue. So the bottom images show bone graft material, and I'm sure you will be exposed to sticky bone and all that fun stuff. So yes, this is sticky bone, and there's a barrier membrane, a real barrier membrane, a vortex type, a PTFE, and then because of the sheer lack of soft tissue, I have to build the soft tissue. I can't build it from nothing. I'm going to the patient's palate. This is a classic connective tissue graft, SECT, subepithelial connective tissue graft. And you can see on the graft, you see a little bit of an orange, which is some fatty adipose tissue, which is quite common in the palatal area. And then you see more of a pinkish white fibrotic tissue, which is the good connective tissue. And then we see a lot of reddish loose tissue, which is a kind of a loose connective tissue in the interstitial area. So that was all brought together. Now, this is a paper that I was involved in publishing, and I was so just lucky and honored to be part of this group. This is a group of periodontists from Korea, no less than Seoul National University. So the Seoul National University, they actually did a prospective study, and we tried to see what happens when you do a connective tissue graft in conjunction with immediate implant. In my case here is staged, but this is in conjunction. And this was a brilliantly done paper. And this paper shows when you do it immediately, it's even better. So that's what we tend to do nowadays. Those of you who know Jill Park, who we do a lot of courses together, she's somehow become an expert in this kind of an area, and she and I, we give courses on the anterior implant. And in that course, we typically emphasize how soft tissue grafting simultaneously is not a bad idea. Difficult, yes, challenging, but it's a good idea. So here you can see the flap manipulation is a little bit sophisticated. We have to loosen the periosteum, advance the tissue, and basically the connective tissue graft is used to fill and volumize the area. And the early result is promising. A patient is wearing a stay plate, and you can see that the soft tissue loss is somehow gained, but the last image shows that the thickness, the width, is still not there yet. We still are a little bit shy on the bone part. When we go in, this is, I believe, several months, 4, 5, 6 months, somewhere there. When you go back in, the promising thing is there's health, there's lack of inflammation. Tissue is very robust and strong. What you also see is that the tissue is thick. What is important to the thickness of the tissue? I mentioned it in the earlier criteria. The thicker the tissue, the more the blood supply. Therefore, the thicker the soft tissue, the healthier the bone underneath, especially so when this is young, immature, growing bone. It needs all the blood supplies like little kids. I mean, you have to nourish them, you have to feed them, you have to give them diapers. I mean, teenagers and adults, they tend to grow up on their own, but the little infants, they need tender loving care, and this is the type of a situation. The thicker the soft tissue, in other words, the thicker the parents' wallets, the better the kids tend to survive. And there it is, the soft tissue that has brought this nice bone. It's not perfect. It's a little bit shy, but it's a very good beginning because remember when we started, we had a huge Grand Canyon sitting there. I was bold enough to be able to say, let's put the implant in now. I'm going to add more bone, but I felt pretty comfortable placing the bone implant because the bone quality was such. And the implant is placed. What are the criteria? I need to have more than 2 millimeters of facial bone. So take a look. The membrane positioning, which is indicated by that straight line at the line angle, the facial line angle, when you join the adjacent incisors, that gap is at least 2 millimeters. How do we get there? I place the implant palatally. I place the implant that is of a smaller diameter, and I place the implant deep. We'll come back to these points later on, but these are the strategies. Remember the very first case, a huge egg on my face? Because I did not know this back then. I placed the implant too far facially. There's no place for bone, at least, not for 2 millimeters, because the implant positioning did not allow that. So you see the huge improvement here. Now the implant is palatally placed and deeply placed, and more so, small diameter. With the dentist system, you are able to do all that because we have a variety of implant sizes, superior connections. So all of that is possible when you use a system like dentist. Further bone graft is done. Yet another membrane is placed, and this membrane is actually a titanium reinforced because holding that space for bone to grow is critical. If it collapses and there's no space, bone simply can't grow. 4 criteria for GBR to happen: space maintenance, availability of pluripotent cells, barrier concept or separating the cells, and then lack of micromovement. These are some of the basic fundamentals, and we're doing GBR, so we have to be true to that. And as a result of that second surgery, the image on the right says it's looking much better. What's real promising is we did not lose the papilla. The papillae are still intact on both right and the left, and that's very promising. It's almost the same position as the initial healing, except we have more facial volume. So at this time, I'm not going to take a chance. I'm not going to disturb anything. I really want to preserve all that, keep all that meat, so to speak, and not lose any bone. So we did a little bit of a fancy split finger flap design. Pull the membrane out, check the implant. What do? I can't let the patient go with a healing abutment. I need to sculpt the tissue. How do you do that? I basically put on a custom abutment. And as you can see on the bottom, that's actually a PEEK material, a beautifully contoured abutment that goes in, and that keeps that contour. That allows bone and the soft tissue to fill in to that predetermined space. So chairside provisional is made, and all that soft tissue is packed around this area with fine sutures, and I'm hoping, I'm praying that black triangles disappear. And it does. I think I must have prayed really well. The black triangle starts to disappear. It's tiny, but as time goes, it starts to mature and it looks very promising. And then the final restoration is pretty much zirconia, mill zirconia, that looks exactly the same as the previous titanium, previous PEEK material. Let's be careful with this. Milling zirconia is very, very tricky. So that's all I'll say at this point. So the zirconia abutment is placed, and then my job was done. The case goes back to the restoring doctor, and Dr. Kenneth Kim was the restoring doctor. Unfortunately, he passed away right around COVID time. He basically did the restoration on that abutment, and he prepped the adjacent tooth and placed a couple of beautiful EMAX restorations, just absolutely beautiful. So this is 2010 when the project got started, and I believe in a year later, the case got finished Uh, you know, look at that eyesore. Of course, in clinical reality, you can't see it, but on this large screen, can you identify that little black triangle on between 8 and 9? Tiny, tiny, but nonetheless there. So this was a collaborative work between Spectrum Dental Lab, which is a very high-end lab in Los Angeles, and Dr. Kenneth Kim, late Dr. Kenneth Kim. This young lady has very, very big gingival display, and that I just didn't like the fact that there was that little black triangle. Nonetheless, very small, but it was there. The patient was quite ecstatic, to tell you the truth, and that was in 2011. Take a look, 4 years later, that black triangle is almost gone. So create the right environment with the tissue volume at the bone in the right place, implant in the correct place, embrace your form with restorations, highly polished restorations, and so on, and tissue responds positively. So I just overlaid the image of the radiograph to show what's going on underneath, and voila, that's it. We have a very successful cosmetically pleasing case, and the trick here was to soft tissue was grafted to increase the zone of attached gingiva before the implant. And that was number one trick. Number two trick, increase the zone of attached gingiva by using narrower implant diameter. Easier said than done. As you can see here, I have chosen to use an implant system that has a diameter of 3.5. And that really did the trick. If you look on either side of the radiograph here, you have plenty of bone between the implant and the adjacent tooth, plenty of bone. When you have a choice of having metal or bone, you should choose bone, not metal. But that was not very apparent earlier on. Earlier on, I mean, this is just one example. We used to choose big fat implants, and the bigger the diameter of the implant, the thought was it's more stable, it's stronger, it's more robust, because we had faith in titanium. But the bigger the volume of titanium, it took away the volume for bone. So you can clearly see you can only have one thing in the same space. So less titanium, more bone is a smart way of doing things. Trick number 3. What if you used platform switching abutments? Now, some of you may or may not understand the platform switching concept, but let's go through this case. This is a young lady who was going to lose number 7. You can see in this image that the midline is slightly, not in the center, and there's a little cant. There's clearly a tooth mass size discrepancy in the right and the left. Incisors, centrals are similar, but laterals are hugely different, and that's just the way it was congenitally developed. She too had a sporting accident, and she was a field hockey player, and she was hit in the face with either a hockey stick or ball, something like that. And basically, she ended up with endo and many of these Cs, and then external resorption on number 7 finally blew that tooth away. So there we have it. This tooth was very mobile. So didn't have a choice. I had to take the tooth out without raising the flap, making sure that the soft tissue is intact and pretty. And then basically, that's what the tooth looks like. And then place as small of a diameter of an implant. Here again, it's a 3.5. Dentist has everything from 3.5, 3.7, 4.0, 4.1, and so forth and so on. You really need to know your armamentarium. What tools do I have in my toolbox? Which is appropriate where is one of the homeworks that everybody has to do. So here, by the time the implant was placed in the right position, a narrow diameter implant, and a provisional abutment placed, and this was a work collaborating with the prosthontist, a brilliant prosthontist that comes and works with me in my own office in tough cases like this. He came in and did this beautiful case, creates an emergence profile. The implant was so stable, we have an 80 registered in the ISQ, implant stability quotient, that is, in this device called Ostel. And the implant is placed, again, you see the theme here. The implant is narrow, implant is placed palatally to allow lots of room in the facial, except in this case, the facial of this socket, there's a big void. Now, there are many things you can do. In this case, we simply chose to put some graft in there, sticky bone. Now, there are many other alternatives, one of which is this little tricky thing. Thomas Hahn happens to be my mentor, my personal mentor. He's a periodontist at UCLA, taught me everything that I know. Brilliant, brilliant clinician. And this is his case that was published. He does what's called a crescent-shaped pharyngeal graft. Not that easy. You go to the palate, you take that little crescent, like a moon shape graft, and use very, very small sutures and fill that in. Or what I do with our group, this is there's a name, the last name there's Charles Park. He's your leader. He's your fearless leader in the Dallas area. Son, our oral surgeon colleague, and of course Dr. Eric Park, the science guru. We put the paper together in 2015. Basically, that's what we use majority of the time, including this case. So sticky bone was placed on the facial, a little bit of concentrated growth factors, basically powerhouse of growth factors were placed there. And this is on the same day. The reason why the bottom picture looks a little bit odd is that tooth that was extracted was dehydrated with all the work that was done. And by the time it was placed in almost identical position, it looks a little chalky, dehydrated. But when it was back in the mouth for 6 days and the patient returns, it gets rehydrated, it kind of blends right in. So if you're thinking this is some sort of a trick, no, that is the implant provisional. We call it NFIT, NFIT, non-functional implant tooth. It's a term that I borrowed from late Colmish. Like the Colmish came up with that term. I loved it, so we use it in my office. We actually have a procedure code, which is a non-ADA code. It's one of those special codes that you use in your office that's customized, and it's called NFIT. When patients have an immediate case, we give them the option. You can do an NFIT, non-functional implant tooth. There's an extra charge for it. There's a certain protocol for it. And the advantage is you don't have to wear a flipper. You don't have to have a Maryland bridge or, Essex appliance or things like that. This tooth is attached via screw directly onto the implant, which also means the implant has to be very stable. The beauty of it is you develop the soft tissue profile right from the get-go. Now, my job is done. And this is the prosthetist's hard work that he has to put in, because patient says, I'm going to do all my anterior teeth and I want you to make sure that they look identical and they lined up. So a lot of effort is being put in to correct the midline, correct the cant, incisal edges, this golden proportion, all of this. And eventually the patient agrees to these final set of teeth. And look how gorgeous they are. They're just absolutely beautiful. And you can see that the soft tissue is preserved. Number 7 is the implant, of course. In case you couldn't tell, that's it. And remember, many of these teeth, virtually all of these teeth, have short roots, external resorption. So they have some mobility. So you have to be extremely careful with it. And this is 3 years. Actually, this is going out to just over 10 years now, 10, 11 years of follow-up. The patient moved out of town from Los Angeles, so she's living in a different state now, but every once in a while, I'm her Facebook friend, so every once in a while, I see her smiling on Facebook, and I feel real pleased and happy that we changed somebody's life. So look at that beautiful work by Jim O'Brien. He's a local prosthetist that I work with. Now, this technique of doing non-functional implant tooth, nothing new. This is my 2002 case that was published in 2004, Dental Implantology Update, which is a simple journal. This is a case that I did, and I've described this method of customizing the provisional. If you would like this, just let me know. I will have these articles reprints sent to you so that you can all use this as a reference point. We have to form a seal around the tooth, which is an old concept, but this form of seal is actually why the attached keratinized tissue is so important. I don't mean to bash, trash, or backstab, whatever you want to call other people's work, but many times we just have to state what it really is. This is a case that I appeared in Inside Dentistry, which is a respectable, kind of an article piece journal, if you want to call it that. This case scares me because there's mucogingival defect that is seen. Clearly on that image, there's no attached keratinized tissue, at least not 2 millimeters of it. And as a result, look at the images. When the retractor was put to pull the tissue, you can see that there's absolutely no attachment. You can see that the vestibule is compromised. And does that have something to do with all that bone loss? This is something that I wouldn't be too proud to publish for scrutiny, but a lot of the bone loss is happening, and that's simply not acceptable. Now, this is another piece that I picked up from a social media upload. Somebody obviously felt that this was very proud work, and I'm not going to go into who's who and so on, but let's just learn how to spot problems and good work, because we live in a very noisy world. Lots of information flying left and right, and social media being dominated, and too many influencers who aren't necessarily true mentors or good deed clinicians. Many people just, let's face it, just showing off and so on. Here, somebody is trying to say, hey, you can do flapless surgery. Why flap and cause pain? Well, this person knows one thing but doesn't know the other. When you do flapless surgery, like on the right side, the attractiveness, of course, is more conservative, it's quicker, it's bloodless, it's easier, less pain, you name it. But that to me is a high price to pay, because you're ending up with an inferior result. You're ending up with lack of seal, which is one of the fundamental things that you need around the dental implant. So take a look. By doing punch technique, you have literally taken away all the attachments and compromised these implants for life. Just not acceptable. And this is yet another one of these series where they say, look, just do a guided surgery, go in and punch, which to me is totally unacceptable. This might look reasonable, but take a look very carefully. We could have had a lot more keratinized tissue, and eventually this will end up with a lot. Look at that. There's no more than a millimeter, if that, of keratinized tissue on the facial, and that's a problem. So we have to use innovative techniques. This lady, I had to do a very minimally invasive procedure. The implant was placed, and she was off her Coumadin for almost a week. I couldn't do that for the second stage surgery, and you can see how easily she bleeds because of a Coumadin. So because of that, we decided to make it a conservative. I could not do a pharyngeal graft. I couldn't do any of that. I managed to put the implant in with immediate implant placement, but the MD was involved. We took the patient off and did the Coumadin replacement therapy and all of that. But at this point, a small semi-lunar, minimally invasive, a peekaboo, find the implant, identify, make sure it's integrated, and so there's the implant placement and a simple healing abutment, minimally invasive. So the answer is yes, you can do innovative flap techniques that still gives you keratinization. One thing you need to look very carefully. If you look at that attached zone sitting sort of almost vertically, the bottom half of that is attached. The top half is not attached. I don't have a cursor, so sorry. But the top half, if it's not carefully tucked down, will disappear. So a crucial suturing technique is important. We need to bring that down closer to the attached to the bone level. And as a result of this, would you all agree that what you see ultimately is an adequate zone of keratinization, and later customized abutment was placed, and the final restoration all indicate that the keratinization is adequate, acceptable result. This is yet another case of a patient who's had an immediate implant. I placed an implant years ago. It is that type of implant that tends to lose crestal bone. It is a butt joint, not a conical joint like the dentist implants. We used to place them a long time ago. These are dentist implants that are conical connections. When you have connections like this, we tend to not lose bone very much. And when you don't lose bone, you don't lose soft tissue. So, trick number 4. graft the soft tissue before the implant, and this is to increase the thickness of the soft tissue. Here, soft tissue is not thick at all. In fact, this implant that you can see through is failing because somebody had placed the implant that the soft tissue isn't there to keep the bone staying healthy. So implant was placed successfully, but is that implant healthy? Is it doing its job? The question is probably not. So let's look at this a little bit more. She is a victim of an automobile accident. She had a number of teeth lost and a significant. So then she went and took care for her clinic and to place that everything was fine. Well, the problem was because the site wasn't adequately prepared, the implant is now failing. Not only is there lack of, adequate amount of bone and thickness of the soft tissue, the implant is failing. But even if it wasn't failing, you restored that, that's just not, cosmetically appealing. The patient is just not happy. How am I going to look? So we're going back to the drawing boards and starting from scratch. So let me walk you through how this case was done. You can see the stark difference between the right and the left, where the natural teeth are still existing and where the teeth were lost and all the structures were lost. That implant was useless. So unfortunately, I had to go in and get rid of that. Unfortunately, it wouldn't engage, so I had to use a trephine, which is extremely traumatic. Luckily, in that area, I was able to place an implant immediately. You can see it's right behind where the bone defect is. And I took this opportunity to thicken the soft tissue. So acellular dermal matrix, basically brand name-wise Alloderm, was placed. And you can see after the healing, and the patient was wearing a partial denture, of course, after the healing, you can see that adequate amount of keratinized tissue and thickness of soft tissue is emerging. If you picture an implant in that same spot, it wouldn't show through as much because now the tissue is thicker. Now, I couldn't go to the opposing side, so I actually used acellular dermal matrix, basically freeze-dried skin for this. So when you raise a flap, the bone hasn't changed. There's one implant that has integrated. There's an implant site defect where the implant was removed. That has healed, but the defect is still there. That huge defect has to be fixed. So now I'm going to go in with an allograft block. Now I have to shape this, and people like to call it an inlay block, an onlay block. But in true form, this is an inlay, just like, here's a CEREC inlay that you're seeing, because basically you have to create lots of walls and make these bone blocks fit right in, which is exactly what I did. Now, but for that foreign body of that size to integrate and survive in that area, you need good amount of keratinized tissue, good thick soft tissue that nourishes this area. We have to bring blood supply to the area. We have to provide nourishment. We have to keep protecting all this graft. So tissue thickness is important. And that's exactly what was planned here. We did the first stage of alloderm to give you that bed. And now that bed is being utilized. Because this is going to be a long-term treatment that drags on for month after month, I am using the first implant as a support, just to highlight how that tissue became extremely thick there. That is what's going to give us the adequate blood supply that we're looking for. Look at that thickness that was not there before the graft. I'm taking her provisional, and I don't want any of this to put undue pressure on the graft. So now I'm using the healing abutment of the implant, and that the foil is simply to be used to not allow resin to go in. I'm doing a reline. Basically, I relined the resin, so now that healing abutment is working as an occlusal stop, kind of like a locator, except there's no locator attachment, but it has to be snug fitted, so it's adjusted. And that was in the posterior side. In the anterior side, I am utilizing the cingulum of the remaining incisor to be able to use so that literally this pontic does not rock around at all. all the flanges are taken away because all of that has to heal, allow healing of the new bone. Then sometime later, when the bone has healed, I'm now utilizing the existing provisional, which the teeth positions were pretty fair and the patient liked it. So I'm using them for the teeth positioning guide, basically drilled through the holes right through them and placing the implants in exactly the determined position. A little bit of soft tissue manipulation, trying to play around with the soft tissue, and then the restoration takes place. So again, this is an older case. This is not. This is a BioHorizons case where which I was using. I don't use them anymore right now because these are internal hexes. I'm living in the conical world, including dentist implants in today's world. Ankylos, Astra, Straumann. These are all conical, and dentist is one of them. So I tend to like those over the flat to flat. Nonetheless, this is an old case that involved a flat to flat connection. You look at this and say, that looks fine. Let's go ahead and mill this, which is exactly what I did. And I thought this was fine until I got the case back, and this is the actual mill abutment. I said, that doesn't look too bad. And I said, let's go deliver this. The way this is done, the abutments are milled. And this is a technician that worked on this case. The abutments are milled. These are Atlantis. I actually ordered cast framework. This is an old case. We don't do these anymore. We mill zirconia by and large. We cast a framework, and then provisional restorations are made. So this is the workflow. We deliver the abutment, try in the framework, and do a pickup impression, that is. And that impression registers the contacts, the occlusal reduction, the facial contour. So then the lab will actually go and finish this case with the right parameters, with the contours, with the pontic, shade, all of that. While that's happening, the abutment's still in the mouse. And the abutment has provisionals over it. When the final restoration is completed, we switch them out. Provisional comes out, the final restoration goes in, and I know it's going to fit because it was picked off of the same abutments. So that's the workflow. So if anything goes wrong, huge investment. So the case goes into the mouse, and we're about to embark that exact step. Until I realize, wait, take a look very carefully. Between the two anterior abutments, the amount of soft tissue is extremely narrow. Very, very small zone of soft tissue. Why? Because one, the implants are closer together. Number two, the implants were of larger size. I should have used smaller implants. Three, I guess I could argue the implants could have been placed a little bit more palatally. And number four, these are actually flat to flat. That doesn't have a conical connection, nor does it have platform switching. So when I caught that, I had to bite the bullet and say, you know what, redo this. Watch very carefully. You have to watch this carefully because there's a very subtle difference. I had to send the case back, remill the abutment with different parameters, allow slightly more soft tissue, which costs you significant money because not only is this two more milled abutments, and the lab's not going to eat the cost, I am. And then they also have to remake the whole casting, remake the provisional. So yes, this one is a lost leader. But I had to do what I had to do because if I did not provide her with adequate amount of soft tissue, just a little bit, then we're going to end up with a problem. We're going to have a black triangle right between the canine and the lateral incisor. So that was the kind of, mistakes that cost you significantly. So this is the pickup. Now, by the way, the rest of the teeth got worked on. And, my wife is a general dentist, so she did some veneers and 3/4 crowns and so on. These are all prepared in the same lab. And then ultimately, you see now that the soft tissue between the two implants are slightly wider, and that has now the potential to grow some papilla into the area, hopefully. And the final restorations are delivered. The patient was very happy with the outcome, and we did end up with some, not the perfect soft tissue, but some papilla soft tissue. So again, preparing things ahead of time is extremely important. Trick number 5, how do you increase the thickness of soft tissue? And I've hinted this earlier, simply place the implant deeper. If the soft tissue cannot be made thicker, then allow soft tissue to act as if thicker by placing the implant deeper. By placing the implant deeper proactively, you bypass that body's reaction of trying to lose bone. So crystal bone loss many times is a body's desperate attempt to say, I need more space here. I need to create soft tissue. Therefore, I'm going to eat up the bone. And that's what tends to happen. This unfortunate case of this young lady is where it ended up in a legal battle. These implants were done by somebody in our area. And when she came to see me, she just wasn't happy that there were lots of spaces underneath. Food gets caught in there, it's smelly. And she had sought care for opinion from several different clinicians. Everyone said, oh boy, that's either bone loss or it doesn't look good, or is at least the beginning of periimplantitis, to the point the other side, she didn't even start the restoration. I happen to be an expert witness on this, and I couldn't, do what else. I just had to tell the court exactly what the situation was. There's threads exposed, and when the attorneys ask, why do you think, in your expert opinion, why is this happening? And I have to say, the clinician in charge here failed to put the implant in a proper position. In situations like this, implant should have been placed deeper, and not doing so has caused a permanent, irreversible pathological situation that requires many reparative process. End of story, case is lost, and things like that happen each and every day. This is another gentleman who's had two implants on the left side. One seems to be adequately placed deep enough, but there's a mistake. Large, that implant is way too large for a bicuspid. Now on the molar, it is too small and too superficial. So lots of mistakes on the same area. So this is Eugene. I'll bring back to his case. In fact, he came and saw me as my last patient today. He just left the office. I'm still at the office. So let me come back and show you the case, but I do want to show you this case of how to place implant deeper. Here, as you can see, the upper molar has super erupted. You can see I'm desperately reducing the occlusal height with the burr marks, so trying to gain some restorative space. But the other thing I can do is place the implant as deep as possible so that some restorative space will be created, which I did. I placed the implant very deep. If you want to look at the radiograph, you say, are you kidding me? From the crestal bone on the distal of the second molar to the platform, that's about a 4 or 5 millimeter drop. You say, how on earth you place it that deep? Well, let's watch this carefully. We do have enough room for restoration. This is a case that I was helping the restoring doctor. I placed the implant, but the restoring doctor was having a tough time, rightly so, because it's so deep. And also, working with a lousy lab, because look at the porcelain finish. That is lousy. You don't want to create that sort of a lousy margin subchangeable. Anyway, I didn't have a choice. That's the way the lab had brought the case in, and all I did was help put that case in. So there's open margin, which is terrible. Look at the date, though. This is 2014. The bone has remodeled, but let's follow this up over a year and a half. Day of the surgery to the far left. 2 months after the restoration place. The restoration was not the best, as you can see. Open margin, rough porcelain margin, and so forth. But look at the right image. This is 15 months after the middle image. So just over a year. Look at the remodeling. Pay attention to the distal aspect and the mesial aspect of the implant abutment. Don't you see lamina dura that was not present? This is an implant system that has conical connection. It also has what we call platform switching. And by doing so, the bone grows over. So placing implant deep for this type of implant system and connection design is not a problem. You, in fact, gain bone health by doing so. So dentist has exact same connection. So this is the kind of thing you can do all the time. How deep can you place these implants? Well, let me give you a very graphic example. This is a 2008 case. This patient, this is Eugenia. Eugenia has a lot of periodontal disease. She just couldn't get things together. So at this point, we just lost this tooth. And she said, Doc, I don't know what I can do. I don't know if I can afford implant. So I felt really bad. So I just basically took some alloplast and just shoved this in. I don't think I even charged the patient. I said, you know what, let's just preserve the bone. So I didn't have a high hope. I just put some bone graft in there and didn't think much. A little while later, she says, you know, I am going to do the implant. So she came in, we decided to do an implant, and a 9 millimeter short implant was placed. This is pretty early, so you can see the bone graft particles of alloplast. Now, alloplast is something that we shouldn't be using as a first choice. Now, in this case, you know, my justification was it wasn't the patient's choice. I was just going to give away the treatment. So I basically literally took what was on the shelf and used it. And I wasn't hoping very much. So the implant was placed right at the bone margin, as you can see here. And then some incredible things started to happen. As the patient was sent back to the restoring doctor said, I am having difficulty taking impressions. So I actually helped him take the impression. Then I realized what happened. Bone grew upwards. Implant didn't go down. Bone grew coronally to the point where impressioning was challenging. Seating the abutment required a very long screwdriver because there was a long screw channel. That bone, I could not believe my eyes, and I said, that's going to disappear. Again, this is an implant system that has conical connection. It has an offset at the abutment level, which means it is a platform switch. This is 6 years later. And I said to myself, that's not going to last. It's going to disappear. 9 years later, 10 years later, it still looks the same. In fact, she's still in the office, and we are now celebrating 13 years. And we are about to take a CBCT soon to verify that the bone is still good, and it sure is. So, you know, from something as bleak like this to very, very stable crystal bone, the bottom line here is placing implant deep is fine and acceptable. The catch here is you have to place an implant with these parameters. You have to use the conical connection. You have to use implant with platform switching system. Look at the amazing new bone growth. If that was a flat to flat butt joint, external hexes, internal hexes, trilobes, and so forth and so on, you will see all of that bone destroyed. So that is one of the take home. Preserving the gingival complex. That's the next trick. Preserving the gingival complex. What you have, you don't want to lose. And one stage is doing the implant as one stage. Don't submerge, put a cover screw, which is dogmatic. But people still find that to be, you know, challenging. One stage is the answer. And how do I know? Well, let's put it this way. When implants were first developed, there were two schools of thoughts. One was the Bredemar team. The other one was Straumann and the Straumann's early followers. Bredemar's team insisted the implant has to be completely sealed because it was an orthopedic surgeon who was leading that team. And in the orthopedic field, you know, you felt anything in the mouth with oral cavity, with bacteria, microbiology, you know, leaving it open just didn't make any sense. But we as clinicians and dentists know that does work because the Straumann's team had shown that one stage and two stage surgery didn't make any difference. Here's an interesting paper that you should be familiar with. This is a paper, and I'll read the title. It's called The Spontaneous Early Exposure of Submerged Implants, and it's a classification system. So according to this, a classification for exposure of submerged. In other words, you try to do two-stage, and something goes wrong. And the class 0 is the mucosa is intact, but there's an abscess underneath. Class 1 is there's a pinhole opening. Class 2 is this and this and so on. Hear me out. When there is a classification for different types of problem, there is a problem. Then why are you doing that? Don't do that and do a different alternative procedure. Here's a case in point. This is a case that I had seen, a bizarre case that was referred in. And the patient is having all kinds of pain, chronic inflammation, and patient's going crazy. And the treating doctor couldn't figure this out, so he referred the case to me, and I said, inflammation. And then I looked, can anybody see it? There's a tiny hole way back in the third molar area. That hole is exposed, class 1, according to that previous classification. Bacteria going in spreads laterally, and all 3 implants are now affected. So all 3 implants have infection around them, low-grade, chronic inflammation, and this is not even loaded yet. And the patient's having so much difficulty, pain, unusual sensations. She was getting psychosis to the point all the implants had to be removed ultimately. And there's a pinhole exposure. And sure enough, there is some chronic inflammation. So yes, when you do submerging, you tend to get these types of issues. So, what this paper is saying, 13% in the maxilla, 15%, 13% in the mandible, and 15% in the maxilla get early exposure. That's more than 1 out of every 10. That's a lot. So I say, don't do that. And if you're worried that submerging and non-submerging, there's an issue, success rate for non-submerging is very, very high, more than 90%. And this is paper after paper after paper I can quote. So this is the early Straumann system. They did 1-stage surgical protocol right from the get-go. They never did 2-stage surgical protocol. So let's look at some of these interesting cases. This is a case that I treated. You can see it's a very complex case. It was a messy case. Somebody really took this patient into town and lots of terrible implants were placed. Now, I took this case over. Let me show you what I'm doing here. Gingival graft. It's done. 1-stage surgical protocol. I took the tooth out. Okay, so now the site preparation is all done, and you're familiar with this, right? Gingival graft, they make the soft tissue thicker and all that. And then 1-stage surgical protocol. Do you have to submerge? No, there's absolutely no need to. You open up, there's healing bone, implant goes in. This is a dentist implant, dentist S-clean type, which again, you can easily see that there's a platform switching. The yellow or the golden color represents the actual abutment diameter. Implant diameter, of course, is wider than that. And you can see we have 2 millimeters or more of facial dimension. The implant is placed deep. Smaller diameter implant is placed. Implant is placed slightly to the lingual to allow more buccal bone to happen. All of that, I verify that the implant is in good position, that abutment might work well. This is a pro kit, which is a template for the actual abutment. I check all those parameters. Implant is extremely stable. Graft the area so that we have excess bone. This is a concept called contour grafting. Healing abutment goes on, 1-stage surgery. And then soft tissue is managed. Now look at that soft tissue. That is thickening, that is increasing the vestibular depth, that is increasing the amount of keratinized tissue. And 2 months later, look at that. There's no exposure, there's no chronic inflammation. All the soft tissue around the implant and the natural teeth are all healthy. Then we simply checked the integration. And of course, integration is excellent. Stock abutment. I'm using a very simple stock abutment, which is exactly the same as the one that I had tried in on the day of the surgery. So we get to the same dimension, put that abutment in, we're all happy. And then we simply make a chairside provisional to give occlusion so patient can function pretty much right away. That allows more bone maturation, and ultimately a definitive restoration is placed. A nice contour, nice embrasure form, nice soft tissue. And years later, we have very, very healthy, uneventful case. So putting the implant as a 1-stage surgical protocol can preserve all the gingival complex. And another way is, like in the last case, it was a stage 1. When you do an immediate implant placement, That is a much easier way to do it too. Here's a gentleman that's losing that second molar. He's a young man. He's losing the second molar, and unfortunately, the third molar is involved. They're communicating. So this is what I had to do. Jason was referred in, and he didn't know what to do. Now, take a look at that second molar. Tiny, tiny bit of keratinized tissue. We can't work with that. We definitely need to increase that. Well, what if we said, let's preserve every ounce of that, not lose that, and see what that does? Well, the big challenge here is I have to go in and take out the wisdom tooth as well. What is the big challenge? There's a lingual nerve that goes past right close to us, and I want to make sure we don't damage that. There is the sulcus, there is the keratinized tissue, and that blue line is my incision line, light blue that is. Why? Because that is the way to preserve the keratinized tissue. It allows me to access the third molar, but we are away, far, far away from the nerve tissue. So with that flap design, I'm able to open this wide, which is good access. Now I can take the second molar and the third molar out, and here's the part of the operation of the third molar extraction. Remove them piece by piece so we don't damage anything such as the IA bundle, nor do we want to damage the very fragile bone architecture, which is truly needed for the second molar to succeed. And then the second molar is removed very carefully. Bone contouring is done. And now what? Immediate implant. Could you have imagined this guy's that crazy? Yes, go ahead and place the implant. Now, here's the key thing. This lecture is about soft tissue. So now I'm taking that little triangular area of tissue that was sitting posteriorly to that second molar, literally on top of the third molar, and say, bring it forward. That's where we need it, on the buccal side of the second molar. And how do you keep it there? You keep it there by using fine stitches. So here is piezoelectric surgery to get the osteotomy site. And there's the osteotomy that you're staring at. Here's a dentist implant. This is a wide body. This is a 4.8 diameter, anchored right into that socket. Very strong stability. Check that the abutment is going to work because I want to simplify the workflow, use the most inexpensive and the simplest abutment. Not only that, the one-piece sole abutment gives you the tightest connection. So make sure that that's feasible. I said that is possible. And look at the healing. Do you now see that with the healing, there is much bigger amount of keratinized tissue on the facial? And the way I did that, let me go back. I'm in a hurry to get a lot of material squeezed in, so pardon me if I'm sounding a little bit disorganized. What you see there immediately on the facial of the healing abutment is a ton of keratinized tissue, a lot more than how we started. But how did we get there? I put some grafting material into the sinus, the socket. But I also wanted to make sure that this CGF, or the concentrated growth factor, is preserved. That soft tissue is preserved beautifully. Bring that forward, make it into a chunky tissue. And how do we keep all that close to the tooth? I use what's called the Lewis button. The Lewis button is a device that is pushed in. It's a piece of plastic. It's very unique to this company. It's a dentist manufactures and distributes it. And it goes onto their healing abutment. It's a very tight, snug fit. As you can see, I'm struggling with a mirror handle to get that fitted in. And it's a very, very snug fit. So once I have it placed there, this is what it looks like. That actually helps to push the tissue down and preserve it. The upper one is typically how you end up with, crazy sutures. The bottom, see how neat that is. And that tissue could have easily been lost, but that was pushed down. This is immediately after the surgery. Take a look. Look how beautiful the soft tissue is now. We have abundance of keratinized tissue, all directions, 360 degrees around the implant. Eventually, the impression is taken. We actually make the provisional. So for the sake of time, I'm going to race through this part. And eventually, final restoration. Too many slides. I shouldn't have put that many slides. It's an overkill. But finally, I put in the final restoration, check the occlusion, And as a result, we have beautiful final result that's quite, soft tissue friendly. Now, this article just appeared in Dentistry Today this month, October of 2021. This article you'll find in Dentistry Today. So that's the case before and the after. Okay, another trick to how we preserve the gingival complex. Sensible socket grafting. I can talk about this topic for hours and hours on end. Let me see if I can save some time because I think I prepared way too many slides here. I sure did. Why don't I show a couple of cases for you, for example. This is a case that was referred in. Somebody had done an extraction and confessed, look, I really don't know how to do socket grafting, but I think this patient needs a graft and needs an implant. Can you handle it? So the case was sent in a couple of weeks after the tooth was extracted. So this is, it's a mess. The buccal plate is gone. There's huge defect. There's not much bone in there. So by the time I flap this open, this is maybe 3 or 4 weeks after the tooth extraction, it's chaos. There's no way bone can grow there. So what do I have to do? The right thing to do is remove all the non-bone forming. So this is the way it should have been on the day of the extraction. Clean all the soft tissue out, and then I had to fill that with sticky bone. It's a combination of xenograft and allograft. That day I must have run out of CGF for some reason. So I'm trying to use basically collagen dressing. Call it plug, call it tape, any of these work just fine. All it does is hold the clot together. Nothing fancy, no membrane, just a little bit of collagen dressing to hold the clot together. And you might think, how's that going to work? Well, take a look. The patient already has a lot of keratinized tissue. We just have to preserve it, not lose it. This is early healing. Okay, we didn't even get primary closure. This is maturity at several months. This is probably 4 months afterwards when I'm ready to do the implant placement. Now you see the keratinization is ample. You can see at the bottom of the screen the demarcation between the white, pink, and the red. That line represents mucogingival junction. And when you raise or flap, the bone ain't too bad. It's pretty decent quality. When you drill right through, remember that was where there was a huge hole before. All that bone is regenerated. There's no magic here. It's just pack bone and let bone grow. The only way the bone can grow really well is if there's good flap over it and if non-bone forming cells, namely soft tissue, periodontal ligament, granulomatous tissue, junk, all of that is completely removed. Then the body will simply lay down bone. Very, very simple. There's nothing fancy about socket grafting. I think it's overblown. People talk about way too many things, too many materials. I think it's overblown. So then I simply place an implant. This is a Nobel Active. It also has the same features that I've been singing about. Conical connection, platform switching, aggressive threads, all of those, except it's not as good as the dentist implant. I'm going to be very frank. I stopped using these because they lose too much bone. Nobel Active. These are something I don't recommend at all. In fact, they don't. They're phasing that implant system out. So this is a healing abutment, and you're familiar with the Lewis button. The Lewis button is placed so that the soft tissue can be maintained well. It's pressed down, and as a result, we get very nice resolution. And here's the implant. We are putting the abutment in, and then the soft tissue forms. My job is done. The patient goes back to the general dentist, and general dentist does the final restoration. He chose to do a screw-retained restoration. So here it is. Humongous bone defect, just a simple management, and then that allowed all that soft and hard tissue to return in health. So there's not much to it. Trick number 9. Once we create all this healthy tissue, we have to have a very smart long-term maintenance plan so that the emergence and embrasure, the physiology can be maintained for many, many years to come. So let's look at this example. This lady is a medical doctor. She's a physician. She had a single tooth implant in the lower right, not doing very well. She's constantly having smell. It's just irritation and things like that. When I probe the area, this is lower right, this is number 31, and the facial, there is no keratinized tissue. In fact, what you have there is pus discharge. No attached gingiva, very shallow vestibule, and that is a problem. When you raise a flap, you can see that there is no bone, lots of threads exposed, and that's an issue. So what do we do? And you can see the corrosion on the implant platform. What does that tell you? It's an internal hex. It is not a conical connection, which is robust, which means it's leaking, which means bacteria is pumping in and out to the point where corrosion happens on the flat surface of the implant platform. That is just not good. So implants coming out. The abutment looks ridiculous. It's coming out. What's adding insult to injury? Right next door, there's a class 5 restoration with an overhang. Why do you create an overhang on the furcation fornix? You're trapping bacteria in there, and the bacteria is going to communicate with the implant. Get rid of it. Open up the furcation area so it's manageable. So we're doing lots of things here. This is such a large hole, I had to graft it, had to come back in another time. CGF, concentrated growth factors, I'm sure you guys are familiar with this. Let it heal. 3 months have passed, and the soft and the hard tissue is adequate. Now I go in, sure, bone is of good quality. But here's a problem. The bone is at a slant. The lingual peak is taller, buccal peak is lower. So what do I have to do? I have to go and flatten that. How do I do that without cutting the lingual nerve? I use a piezoelectric surgery. So the lingual peak is flattened. Now I'm placing an implant of the right type, conical connection, platform switching, aggressive thread. This actually happens to be a Straumann, very similar to dentist. And then the implant is placed deep, little palatally, smaller diameter than the previous one. And then the facial defect is now filled with GVR. Okay, you guys are very familiar with that. Furthermore, what do? Initially, this patient did not have adequate depth of the vestibule. So what do I have to do? Create it. Swing that soft tissue around. All the keratinized tissue that was on the lingual side is now swung over to the facial and pushed down. Do you see the difference? Keratinization on the facial, mucogingival junction pushed all the way down to the bottom, and the thick keratinization. In fact, that little nipple or that extension just happened to not go away. So all we had to do is just excise it over, which is kind of a shame because I could have added just a little more of keratinization. And then when we do the restoration, this is when creative embrasure form comes in. I'm working with the lab. I'm literally designing this myself back and forth, create an embrasure that allows clean healing. Create an embrasure that allows soft tissue and hard tissue to be in harmony, but at the same time, be able to, clean. And this is the final results based on a tie base, but the tie base was of a nice angle. That's how it's delivered. So now you can see we rectify issues like this by doing a number of tricks. Make sure that the occlusion is helpful, make sure the patient is wearing a night guard appropriately. And as a result, we are now able to maintain the bone much better than how it used to be. This is my little chant. Embrasure is spelled with a capital S. Embrasure is spelled with a capital S. That way, soft and hard tissue can be maintained. This embrasure was spelled with a capital C, over contouring. Ooh, for the sake of time, I wanted to skip, but this is an important one. I do have to cover this. This picture illustrates exactly what we are talking about. This actually is a dentist implant. The diameter of the implant is wider than the actual abutment, which is represented by the white. So there's an offset. That's what we are talking about when we say horizontal offset or platform switching. The implant is placed slightly deeper. We can go deeper, right? But for diagram's sake, the crest of the bone is, say, 1 millimeter taller than the implant platform. And this allows a harmonious soft tissue to form. Now, this group of Japanese scholars in an old paper, 2006, they wanted to know exactly this. What is the appropriate height and width? Is there such a thing as an ideal ratio? What they did, they took a bunch of their own cases that was completed restoratively. They all had to have 1.5 millimeters of attached keratinized tissue. They all had to be restored for more than a year. In other words, something reasonable. They removed the restoration and they measured all the parameters after they took some impressions. So they measure the height, the depth, all of these parameters, and then they start to look at this. Now, they don't call it this, but I'm calling it the biological width, okay? The biological width, to me, from the platform to outwards, in their data set 3.44. The biological height from the same parameter, from implant platform to the peak of the soft tissue, was 2.1. So it's wider than taller. Of course, you can't have tissue growing up into the air. It has to have some base. So according to their analysis, it was about 1.16. That was the ratio. You have to have 60% wider base for the height to happen. You can have a narrower base to have a tall height. But how can you fold the body? Well, there are three strategies. One is to under contour, give that an embrasure. That soft tissue can spill in sideways. If you over contour, it simply isn't going to work. If you over contour, you're going to crush the soft tissue to move in the wrong direction. So to increase this ratio, to enhance this, you accommodate by doing the embrasure form. You honor that ratio. And to do that, you increase the volume at the base. That's why you do soft tissue grafting. That's why you do contour grafting. That's why you add more bone and width. That's why you decrease the implant diameter whenever possible. So that's how we get to these numbers. So let's look at another example that describes this. I've given this lecture multiple times, and we talk about this type of topic. So one of my students basically said, I'm going to listen to this guy, and she, rightfully so, did exactly what I told her. She overdid it. Look at the S-curve. The S-curve is a little bit too accentuated. Now, you can see that because I've told you, but the real problem was this. She didn't know what was happening because she said, I did exactly what you told me. The lab followed instructions. So I delivered. And then all of a sudden, I lost soft tissue. I said, what do you mean you lost soft tissue? You sure nobody just dug into it? No, she said, there was keratinized tissue. Now it's gone. So she shows me this picture. I said, how can soft tissue there disappear unless you went and massacred it? She said, no, nothing was done, nothing physical. It was gone. Well, to my surprise, when I opened this up, I realized that was broken. So this is a problem when you use tie base. When you use tie base with very low cuff height, you can see in the image, then the zirconia becomes so thin that you end up with a problem like this. And that caused more bone loss, and that bone loss caused soft tissue loss. You should not be using tie bases like this. My spill is just, I cannot emphasize it more. These are all tie bases. Ugly, stupid tie bases should not be used. Over contouring forces you to over contour. So in this case, this is the gentleman that you saw before on the right side, the left side, right side of the screen. This patient comes in to have the right side treated. The second molar is going to be removed, and then the third molar is going to be removed as well. So the trim plan is to have a single tooth implant in that second molar. So there we go. We take the third molar out. We take that second molar out, clean all that out. And, we've got some dead man's scrap gold, which is great. Now I'm going to drill a hole, an osteotomy, right in the interseptum area so I can place an immediate implant. You all understand the advantages of immediate implant. Not only does it save time, but it preserves the gingival complex. So I place an implant. This time it's an Astra, very similar to dentist configuration. In fact, dentist copied more or less the Astra connection. So the implant is placed what? Deep. You realize the connection is a conical connection. You realize the diameter of the implant is pretty narrow. You realize I'm far away from the buccal bone contour. In other words, I am ensured that I will have at least 2 millimeters of bone on the facial. Sticky bone is used to enhance, stuff all that in. CGF is used to stuff all that in. What did I do? Did I submerge it? Tricky. It looks like I've submerged it. This is what I call automatic second stage. So I put in a relatively low healing abutment, and then I allow tissue to heal by itself. And guess what? Several months later, soft tissue starts to peel away, exposing the healing abutment all by itself. There is October, This is in December, less than 2 months, it opens up. But that short while when everything was closed made the area heal much better. And in 4 months, I am ready to go in and simply take that healing abutment off, check the embrasure, and then put in a taller healing abutment. Then I am training the soft tissue. I need to train the soft tissue so I can make that contour better. So I take a scan. This is a CEREC that I was using at that time. And then we did a chairside provisional. And I create this form to train the soft tissue, to contour the soft tissue. And basically, this is all sent to the lab. And then the lab sends me this. That's a shoe. That's not a tooth. That looks like a boot to me. It's just poor contour. I got really mad. I got really upset. So I wrote all these to the lab. I need a gradual embrasure. I need that S-curve, gradual S-curve. I need to have the finish line drop so that, there's better axial surface for better retention. I need to have point contact, all of these things, which I thought was elementary, because you see, that soft tissue contour is what I trained with resin provisional, but the final restoration wasn't even close to that. So this was the first attempt. And look at all the problems. Look at the V embrasure and the occlusal and the medial occlusal. Marginal ridge is too short. That's going to cause food impaction. The S-curve is very accentuated. It causes food impaction, plaque trap. There. All of these problems that a high-end lab should be doing. As a result of many of these encounters, now I do my own lab work. I have a milling machine. I have software. We use ExoCAD. We use a 3D printer. We use print ray printer. We do all of these things, and we just do things in-house because I'm sick and tired of labs not doing their jobs properly. So this is what I wrote to the lab. And lab then finally listens to me and brings this back. This is completely modelless, well, completely digital. So here is the final restoration that looks a little bit better. The contours are all better. And I put a lot of effort behind the scenes with the digital design and so forth. And finally, I get this restoration back. Now we're talking. Now this fits a lot better. Now the restoration makes sense. I'm using a screwmentation method where I put cement, screw it in, and then bring out, clean that out, polish the zirconia until you can see your face in it, nice and shiny. That's exactly what the zero bone loss concept shows, and deliver. This was about 4 years ago, I believe. Check the occlusion, make sure there's non-axial load gone. Take a look at that. This is as good as we can get. There's no embrasure on the top. That's gone. The much more accentuated S-curve is gradualized. The bone looks healthy. So this is the way the case was delivered. This is the before and the after. This was today. I told you the patient came in today. So here it is. 4 years later, I want to see a short video clip of the CBCT that was taken. Is it moving? Is it moving? Oops, I have to show you this. Okay, here it is. This is not moving. So here, you see how I am now slicing this, and take a look at that. You can see the cross section of that implant, and I'm going to drag it in so it's actually occupying a bigger surface. Look at that. You can see the IA bundle down there, and IA is far away. The implant sits right in the middle of the jawbone. Plenty of buccal bone, plenty of lingual bone. Look at the nice embrasure. You saw the mesial and distal on the PA and the panoramic, but in the CBCT, you can see the buccal and the lingual embrasure, which is identical in the same manner. Gradual contour, very narrow neck. Connection is robust, so you don't see any bone loss in that connection area. There we go, same image again. And this is something you can be very proud of and the patient very happy with. So he just left my office a couple hours ago looking great. And we also, I told him how famous he is because his case is being shown around the world in my lectures. This is not the same case. Similar area, similar spots, same protocol was done. The implant was placed. This is a flat to flat. This is an old case. Look at the dates, 2013, almost 10 years ago when I was using some flat to flat. And that contour was created, and I liked that. And I sent the case back to the restoring dentist, and that S curve became a C curve. That's just not going to work, and you're going to start to lose bone. And sure enough, give it a couple of years, and we lost bone. So we had to redo that case. We had to do some laser therapy. I had to rebuild some bone and recontour it. That's a lot of unnecessary work being done because of somebody not getting the contours right. Lastly, trick number 10, long-term maintenance. How do you do this? You have to use home bleach therapy. Soft tissue has to be kept free of microbes. Everybody can read this on your own. When the dentist asks you, when was the last time you flossed, your response should be, dude, you were the one that did it for me last time I was here. That shouldn't be the case. I should be flossing every day. This is my proud team. Ashley, our hygienist, Alexis, my assistant, and my wife. They basically put a little effort into putting this together because this is a diluted bleach therapy that is now widely accepted and being worked on. In our office, virtually every implant patient does this. And basically, it's a 20-to-1 dilution of plain Clorox put into the water pick and used as a irrigation, so the subgingival microbia is killed on a regular basis. Don't use chlorhexidine, it doesn't work. This is the way to do it. And then you want to use this Proxatip, which is something I highly endorse and use. And this is a home bleach therapy. This is what the patient walks home with. Extremely important thing to do, works extremely well. Let me show you what I'm talking about. This is a lady who is she's very good with her hygiene, but despite so, she's losing some bone. That first molar, number 14, natural tooth, that distal furcation. So this is actually bleach, okay? And we do this in the office. Now at home, she should be using a water pick so that the water pressure carries that bleach solution all the way to the depth of the pocket. If that pocket was, let's say, 5 millimeters, regular rinsing will only get you to about 2 or 3 millimeters. Only when you use something like a water pick or a monoject that's pointed directly at it, then you have a chance to get some of that solution to that depth of the 5 millimeters. A chance. But you need to get it down there to kill the bugs. So this is the same patient. And the pocket, there is a pocket there. I mean, how do you keep that area bacteria-free? This is not an implant, this is natural tooth. She is meticulous. She has no plaque. She has a gingival graft here and there, but constantly bugs are sitting there. So you have to use bleach on a regular basis. But what about patients that don't have good hygiene? This is a lady. Let's look at this implant. This is an implant that I placed years ago. She comes back one day with acute subchronic abscess. Humongous. She's in pain. You see pus draining. You know what? No worries. We simply put the patient on home bleach therapy. She goes home, uses it. A week later, she comes back. This is what it looks like. There's no need for antibiotics. There's no need for flap surgery. There's no need for laser. When things like this happen, get rid of the bacteria. It's because bacteria is piling in there. We can't get rid of it. Toothbrush won't reach. Floss won't reach. Chlorhexidine goggle does not reach. In fact, chlorhexidine kills off the germs, not the anaerobics, the superficial bacteria, and all it does is cause more anaerobic infection. So you have to shove bleach subgingivally to be able to get it to the source. So that's the kind of thing. A week later, look how healthy the tissue is. Tissue regains its tightness, and we get back to normal health. Okay, because of the time, I'm going to stop right there. I think I have another case or two, but let's see. A quick sort of summary. Now, I take my pride in having a very diligent, very conscientious implant and periodontal practice. This lovely lady is Dr. Ellen O. She's my associate doctor. She's a general dentist, but she works in my office. At this time, when we published this paper, she was a dental student. What she helped me do, we collected data in my office of all the complications. And this is a summary. Over a 10-year span, the 1,000 patients and 2,000 implants that I was able to follow up with, data was included in the study. We went to Vancouver to present this paper. Of this, I'm very generous with the numbers. Of this, 36%, more than 1/3, had some form of complications. Let's see what they are. This is a list. Periimplantitis is the biggest, 33%, and you're probably not surprised. Periimplantitis is very, very common. Down the bottom, abutment fracture, screw fracture, smoking-related, sinus complication, neurosensory, yes, some people have numbness and so forth, occlusal issues, failure to integrate, systemic conditions, prosthetic issues, screw loosening, very common, restoration decementation, very common, bone loss but stable, it's another form of periimplantitis. Guess what number 2 is? Soft tissue problems. Now, my definition of soft tissue problems is very broad. I try to do that because I want to capture all kinds of imaginable soft tissue and prevent them from getting worse. So my definition is a little broad. But nonetheless, for a very conscientious periodontist, the fact that soft tissue problems number 2, I don't sleep very well with this fact. So what I do, I have to think like a scientist, but I have to perform like an artist. In the operatory, you are an artist. You have to bring all of your skills and you have to perform. But you always have to analyze and think like a scientist, not like just copying somebody, not like be a puppet of somebody. You have to think, use your brains. But you know what's most important? You have to serve like a servant. So that's how patients come to you asking you to be their doctor, to entrust you with their health. So with that, I know I've rambled on. I am very, very proud of the GDIA group that we formed almost 10 years ago. And I am happy to see a group of clinicians in Dallas coming together like this. I hope I can be of help in many other ways. Do contact me if you have any questions. And the few minutes that's remaining, I am open to questions and answers. These are all of our graduates. Some of you guys who went there recently are not in there. Oh boy, some shameful pictures. That is Charles. That is your leader right there, Charles. Okay, okay, that's enough. That is enough. Zero bone loss. This is what we're talking about. This is a patient I treated in 1994. Cantilever a bridge, cut that off, place 2 implants. Now, mind you, this is external hex implants. I placed these 2 implants in 1994. It's actually, what is it now? 24? No, it's actually 26. This is not updated. 26 years later, 25 years later, whatever. Those implants are still doing well. No bone loss. We're talking about zero bone loss. And why? It's because I did a soft tissue graft. Did you see that? Look at the soft tissue graft. The chunky tissue, 2 millimeters of the bone, the implant diameter being as small as possible, having abundant bone. This does not have platform switch. It's an old system. But even so, all of that, we're still able to have very, proud zero bone loss concept. So with that, I want to say thank you guys, and I hope to see you guys soon.
All right, thank you all once again for your full attention. Thank you, Dr. Kim, for your valuable time. I hope everybody enjoyed the webinar and found it to be very beneficial. Once again, you will shortly receive an email from GDIA with the course evaluation form. Once you submit the form, you can expect to receive your CE certificate by email within 14 business days. Also, please visit gdia.com to check out more upcoming courses. And yeah, thank you, and hope you all have a great night.
We're going to entertain any questions. Is that it? I'm fine with that.
Does anybody have any questions? Last questions? Oh, okay.
Yeah, I guess there's a question.
Yes.
Dr.
All right.
Sohi,
Please unmute yourself.
unmute yourself and go ahead.
Dr. Sohiken? Okay, so she asked, when do you decide between connective tissue graft versus free gingival graft?
Very good question. If you have about 5 hours, I'll really answer it, but in a very succinct way. Connective tissue graft looks prettier. Connective tissue is not as robust. Free gingival graft, which is epithelium, is, you've seen a few of these today, is what people describe as tire patch, kind of almost rubbery, texturized, scar-like, keloid-like. So it's not the most attractive thing, but functionally, it's a lot more stable. So I personally like free gingival graft around dental implants. Some people say, don't ever do a free gingival graft in the anterior zone. I do it all the time. And you have to have an agreement with the patient. If the patient is fine with function versus cosmetics, then we go there. If the patient says, I really want it to look absolutely pretty, then connective tissue it will be. Because the connective tissue is typically laid underneath the flap, so the outer appearance is normal original tissue. Free gingival graft is one can onlay, where graft is placed on top. So now the surface characteristics is replaced with what came as a graft, and the edges usually have scarring and bumpiness and so on. Free gingival grafts can be made very pretty, although it's not as pretty as connective tissue ever. So that's the fundamental difference. If it's around posterior teeth, let's say some of the posterior, deepening the vestibule, trying to get good attachment, connective tissue simply cannot do it. So that's where free gingival graft is much more valuable. I hope that answered that question. That was a very short question. Thank you. Any other questions? I guess you guys are shy to talk. So if you are, you can type it in. That's okay. That's perfectly fine.
I think it's overwhelmed. So many information for in short time.
Yeah. It is. Implants, there's a lot of information in implant dentistry. So I'm sorry, I kind of maybe a little overcomplicated. Well, I think everybody's tired, so am I. So why don't we call it a night? And I hope we can have more of these kind of venues as soon as we can. Thank you and good night, everybody.
Thank you, everybody. Good night.